All right, good morning. Thank you so much for joining us here today. If you are joining us, this is the pediatric behavioral health training. We're going to be focusing on suicide assessment, crisis assessments for pediatric patients, the social worker role through multi-care hospitals, and then transitions or referrals to psychiatric units. And we are lucky enough here today to have Heather Fonseca from the Adolescent Behavioral Health Unit, so one of our multi-care hospital psychiatric units. So we want to be really good stewards of our time today, so I'm going to go ahead and get us started. I welcome any of our attendees to go ahead and put any comments or questions in the chat. I do like for us to know a little bit about where people are joining us from, so in the chat, if you could put what hospital or facility you're joining from, just so we know who's here. And then we'll answer questions at the end. So go ahead and use the Q&A to make sure that we can answer any questions that you might have at the end of today's session. All right. So to start off, my name is Jasmine. I am a licensed independent clinical social worker here at Marybridge Children's. I've been with Multicare for the last 10 years, actually, in both emergency department and inpatient medical settings. And I've actually worked across the system. So I've worked at Good Samaritan. That's actually where I started. I've also been at Tacoma General, Auburn, Allenmore, Covington. And then I planted back over here at Marybridge in the inpatient floors working on the medical surgical units, and then transitioned to the professional development specialist position about a year ago, now providing training, onboarding, support, and clinical supervision to our associate level social workers. And then we also have Heather here.
Good morning. My name is Heather Fonseca. I am on 9 years at Multicare. I started out in our ED at Marybridge and then moved up to cover the med-surg floor as well as the PICU before I transitioned over to becoming the program manager at the Adolescent Behavioral Health Unit here at Tacoma General last December. So my passion is for kids' mental health.
Wonderful. Okay, so starting off with some objectives here today. The goal of this training, it was brought to us that we wanted to ensure all of our social workers, no matter which facility you're in, that are at a multi-care hospital, have the same kind of foundational understanding of providing care to pediatric patients with behavioral health needs. So the goals for today is to understand the care pathway for pediatric patients with behavioral health concerns, being able to conduct the suicide assessment using our safety tool, completing safety planning with pediatric patients, including those lethal means counseling, implementing the Involuntary Treatment Act and how does that affect minors, and then being able to refer patients to appropriate levels of care, including inpatient psychiatric units. So to start off, Joint Commission has outlined specific goals of care for patients at risk of suicide. Part of those goals includes ensuring that we are screening all patients, having a standardized or universal screening process to ensure we're able to identify patients with risk of suicide. For multi-care, that screening tool is the Columbia Suicide Severity Rating Scale, and we have it embedded within Epic. So our nurses in any hospital setting should be doing this screening tool in the Epic flow sheet, which then will alert us to or transition a consult to the social work department to be able to do their assessment. So we are always starting off with that suicide screening to identify who is at risk. For multi-care, our policy does indicate that any patient 12 and up must receive the suicide screening. But if there is other indications for patients 12 and younger, so if they present to the hospital specifically for a behavioral health concern, a suicide attempt or gesture, or suicidal ideations, they can receive the suicide screening, the Columbia, starting at age 10. Once they've been identified, we move into that mental health evaluation. So this is where social work comes in. Just some general basics about when we're doing behavioral health pediatric suicide assessments. We're going to do the same in terms of what we do with our adult partners, right? So you're going to do a chart review. You want to consult with your doctors, making sure, or whoever the provider is, what's the history of the presentation? Is the patient alert and oriented? What's going on that brought them into the hospital? You want to make sure that labs have been completed, that they're medically stable, right, to speak to and do the assessment. And then you also want to clarify or verify if there's any substance on board. If they are intoxicated actively, for any alcohol intoxication for pediatric patients, we need to assess them once they're at a blood alcohol level of 0. And that's per protocols. That's not necessarily per policy, but best practice. And then for other substances like marijuana, meth, opioids, etc., we would be looking at, similarly to the adult population, are they medically cleared? Are they alert and oriented? Are they able to have a conversation with us so that we can truly assess them? So it's important that we kind of know and have a baseline in terms of whether or not they're appropriate and ready for an assessment by gathering this information ahead of time. Next, which is something that is slightly different than when we do our mental health evaluations with our adult patients, is the CATS. So this is the Child and Adolescent Trauma Screening. This screening tool is a practice that we include in Marybridge to make sure we're identifying patients with any trauma history, because we know that this can increase risk of suicidality. So this is a practice, not a policy per se, but it helps provide additional information, which is why we want to make sure that we're doing it. This can be done by the patient or the caregiver. A lot of times I'll hand it to the patient as I go and speak to the caregivers privately, so they get some time alone to work through the form and answer honestly. And then when I get back to talking to the patient, I'll go ahead and look through it, ask any additional questions about any answers that they've provided to gather any more information that I might need. With the CATS, it has that scoring technique, right? So on the back side of it, there's page 2. It's on the left-hand side in this presentation here. That is what we're scoring. So in the last 2 weeks, have these things impacted you to a certain severity or a certain level that we need to be aware of? And that can be indicative of post-traumatic stress disorder. And so that's part of the reason we want to make sure that we're doing this screening as well. So now I want to move into informed consent. So this is something that we need to be talking to patients and families or caregivers about when we're meeting with them. So one of the practices that we would like to do is and encourage is when you're meeting with families for the first time, taking the caregivers out and having a private conversation with them about what's been going on, and also letting them know about informed consent. So if it's determined that a patient does meet criteria for any sort of inpatient psychiatric treatment, there's 3 ways that they can access that. The first way is adolescent initiated, also known as voluntary. So any youth 13 to 17 years old who meets criteria for inpatient treatment and wants to go can actually sign themselves in. They do not need any parental or caregiver consent in order to attend treatment. Family-initiated treatment is for any patient under the age of 17, or I'm sorry, under the age of 18, so 17 and younger, who meets criteria for inpatient services. The patient themselves is saying, no, I'm not interested in going, but the caregivers are agreeable to consenting. And it's also important to note that caregivers for consenting to family-initiated treatment, legally, the definition includes their parent, a legal guardian, a step parent, any kinship caregiver, or other relative who's been authorized to consent for treatment. So that's a wide variety of individuals that can actually consent under FIT. It's also important to know and understand that family-initiated treatment is a voluntary option. So despite the parents' or caregivers' ability to consent on the youth's behalf, this is still considered voluntary, and we must treat it that way when it's been identified for the patient. The third option is Involuntary Treatment Act, or a detainment. This is for any patient that's 13 and older who we believe, again, meets that criteria for medical necessity of accessing a psychiatric treatment. And the way I like to think about this one is it's when the patient says no, they're not willing to go. Parents and caregivers say no, I'm not willing to sign my patient in. And I also were not interested in doing any sort of outpatient services. So they're unwilling to do crisis. They're unwilling to follow through with any outpatient mental health recommendations or referrals. They don't think that there's a problem, right? And that's for the caregiver and the young person themselves. If they meet that criteria, then we can go ahead and refer to the designated crisis responder or DCR for an evaluation. and then consider for detainment. And we're going to talk a little bit more about ITAs more specifically later in this presentation. But in terms of informed consent, it's important that we go over these three different options with both the patient and the caregivers when we're thinking about what potential recommendations you might be making through your assessment. On that same vein, it's also important that we consider and discuss with patients and families about confidentiality and disclosures. So at the age of 13, confidentiality is now up to that patient in terms of disclosing their own behavioral health information. And this does include substance use. So it's not just their mental health information, but any information related to substance use. The biggest caveat to this is if there is any concerns related to imminent or immediate safety, right? And so if we have a patient who is disclosing concerns about suicide, self-injurious behaviors, anything that we consider to be imminent or of concern for their safety, you are at liberty to share that information with their caregivers or with those involved in making them safe. So making sure that you also go over that information with the patients so that they recognize and understand when they disclose certain things that you will also have to share that with them. Now, obviously the minor group is a really large age group, and we have those different laws depending on age. So when we're thinking about assessing patients who are under 13, so 12 and under, we do see that it happens more often than you would think. And so there is some kind of best practices or things that you want to consider when you're doing those assessments. So for patients 12 and under, legally, because they're not at that right for confidentiality quite yet, we do need to ensure that parents or caregivers either give us consent to speak to the patient privately, or that we're having a conversation with parents around ensuring that the patient is answering for themselves. So a lot of times when I'll go and assess a pediatric patient under 12, I will talk to the parents. So I bring the parents out of the room, talk to them privately, and I say, I would like to go and speak to your child alone to make sure I can gather all of the information. Are you okay with that, right? Make sure you're documenting that consent. If for some reason the parents say, no, I'm not interested, I don't want you speaking to them alone, that's their right. And so at that point, I just have a conversation around making sure that when I'm asking questions of the patient, that we let the patient speak for themselves. So I will say, that's fine. It's really important that we let the patient answer for themselves. So if you see that they're looking for you to answer or trying to, have you answer for them, it would be really helpful if you can encourage them or, just give them the validation that they're okay to answer my questions, and go ahead and go into the conversation that way. In addition to assessing young patients 12 and under, it's also important to think about what the disposition might look like. So for patients that are 12 and under, the only way they can access inpatient psychiatric treatment is through FIT, that family initiated. They're not at that age yet where they can consent on their own voluntarily, and so the parents or caregivers have to be willing to sign them in. The other thing to think about is if we are considering inpatient treatment, that we have much more limited access to programs and facilities. So in Washington State right now, there's only Seattle Children's Hospital and Two Rivers. So those are really the only two facilities that will take 12 and under. And as you can see, Two Rivers, which is on the east side, is actually not a locked facility. So it's something to consider and something to talk to parents about when they're wanting their young person to go into treatment, around the limitations, and that there is actually a strong potential that young person will still have to discharge home. So when that comes to making sure that you're also always considering least restrictive options and really thinking about, do they meet the medical necessity for mental health criteria? Do they meet the criteria specifically for inpatient psychiatric treatment? Or can we consider some least restrictive options? Mobile crisis teams. Pierce County is lucky enough to have two that can come out and support our young people and will come to the hospital to help navigate and do safety planning. Considering outpatients, if you're in Pierce County, we have the Youth Engagement Services program that can come from any emergency department in Pierce County to get patients connected to behavioral health services once they've discharged. And then we also have intensive outpatient programs. So WISE, Seneca, Charlie Health is one of our virtual IOP options. So just thinking through, if inpatient isn't an option, what are the least restrictive options and how can we get them there? In terms of best practices for virtual assessments, I know that we have some of our off-campus emergency departments, and social workers may be assessing patients virtually or through telehealth. And so in terms of this, it's kind of the basics around consent and documenting who's around. So you want to make sure that you confirm the identity of everyone that's in the room and that the patient is okay with them being in the room while you're talking. Again, thinking through that age of consent and confidentiality. If that patient's 13 and older, asking for the caregivers or whoever the visitors are in the room to exit so you can complete the assessment. That means working with your nurse partners at the facilities to help kind of manage that and set expectations. If they're not interested in having their visitors leave, then making sure you get verbal consent and that it's documented that they wanted those persons in the room while they were being assessed. For screening tools, because we do the CATS and in some instances we do the CRAFT, right? If substance use is identified, you have to do the SBIRT, which for pediatric patients is the CRAFT. Those are things that normally, right, in our facilities we would give on paper document hard copies. However, when you're doing virtual assessments, that's not always an option. So one thing that I would encourage is these flow sheets actually exists in Epic. So the CATS and the CRAFT are flow sheets in Epic that nursing staff can complete because it could extend your assessment time with patients if you were to go through every single question on your copy and having to talk to the patients through that. So to try and make it as efficient as possible, I would encourage that you work with your OSED managers or clinic charge nurses to see if you could give them physical copies of the form, help educate on where to find them in Epic under flow sheets. Literally, you just type it in and it will pop up for you. And have them kind of support with getting those things documented because it is best practice for us. So those are kind of the big virtual assessment key pieces that you want to pay attention and think about. Okay. Moving through, so now we've identified our patients. We've had some of those early conversations with our caregivers and our patients about confidentiality and consent, kind of expectations. And so now it's time for the social worker to go and do the assessment. MultiCare as a system has identified the SAFE-T as our suicide risk assessment that we use. So this is appropriate for all ages. It is a part of Joint Commission that all hospitals have an identified risk assessment as a part of our suicide goals. And so this is the one that MultiCare uses. So same way you use it for your adult patients, we're going to be using it for our pediatric patients. So I'm going to go through each step briefly and kind of give examples and information about them. So step one is identifying risk factors. So we have here, right, suicidal behaviors, current or past psychiatric disorders, any specific symptoms, hopelessness, anxiety, insomnia, family history of suicide attempts or hospitalizations, any stressors that have gone on, a recent breakup, failing a test, not getting on a sports team, right? Those are things that could really impact a young person, as well as more traumatic instances. They're experiencing physical or sexual abuse or child abuse in the home. There's a lot of chaos, homelessness, right? So those are things that could also impact them. Changes in treatment. So maybe they were recently discharged from a psychiatric unit or they were in outpatient therapy services and that got discharged and now are experiencing a stressor. And then finally, access to firearms. We know that access to firearms is a very, very high percentage of suicide risk when they have access to lethal means. And so that is an important one to make sure you're noting and asking about. The next step is to identify protective factors. So we know that people can have both internal and external protective factors, and you want to assess for both of those. So internal ones can be their ability to cope with stress or their frustration tolerance. Do they have any spiritual beliefs? Are they future oriented? And then on the external side, we have responsibilities to parents, loved ones, or pets. We hear that a lot, that they want to live for their dog or their cat, their horse. Any positive therapeutic relationships, and any social supports. Are they in groups? Are they a part of any sports or community clubs? Do they have adults in their life that they trust and can go to? Those would be external protective factors that we want to make sure we're tapping into. Step 3 is our suicide inquiry. One thing that I really appreciate about this particular approach, the CASE approach, chronological assessment of suicide events, is that it breaks it down into 4 easy timelines to be asking about. So this helps to avoid any sort of omissions. If we don't ask the right questions, we don't get enough detail or information to make an informed decision. So it goes from asking about the presenting suicide events. So anything that happened over the last 48 hours, what brought you to the hospital, right? That's kind of that question. Recent suicide events, so any suicidal gesture or ideation that occurred from 2 months to that 48-hour kind of mark, what behaviors have we had? Any past suicide events, so anywhere from that 2-month mark and beyond, what have those suicidal gestures looked like? And then finally, the immediate suicide events. So as I'm talking to you right now, is there any risk? What are the suicidal thoughts or gestures that might be going on? So this allows you to have and create an understanding of the risk that this patient may have based on what is their experience over time. What does that look like with their ideations, plans, and gestures? It's also important to note the subtle nuances of facial expressions or hesitancy of speech may also indicate that a suicide attempt is imminent. So we want to make sure we're not just paying attention to what they're saying, but what are they not saying, right? What are their nonverbal cues giving? If you've initially gone in thinking, I can safety plan this patient, and then you're met with a lot of resistance or hesitancy, does that change their risk? How can we work around that or mitigate it to help safely discharge them? So that's one thing you want to think about as well. Really quickly, I want to pause to just also kind of make a note around homicidal ideations, that the safety risk assessment can actually be used for homicidal ideations. In the same way that we are asking about suicide, we want to ask about homicide. What are their risk factors? What are their protective factors? Instead of a suicidal inquiry, we're going to ask about homicidal inquiry. You can use that CASE approach, right, in the same way. Instead of suicidal gestures, homicidal gestures or ideations in 48 hours, up to 2 months and beyond, and right now today. And then duty to warn without substantial risk, right, which is how we're identifying the risk, is through that safety assessment. So if we feel like based on the safety assessment that they're at moderate or high risk, a duty to warn would be appropriate and imminent to make, right? But if they're at that low risk kind of threshold, then it would potentially be a HIPAA violation to do a duty to warn if it doesn't meet that substantial risk and that criteria to do so. The biggest piece of advice is always consult if you have concerns about homicidal ideations, that you talk with your supervisor and get their input as to whether or not they also think that it meets the criteria for duty to warn. Heather, do you have anything to add on this section?
I would say for us, when the kids come in, it is fairly common that we do make duty to warn calls and notifications, because we do run into a lot of kids who have very specific plans to harm either a family member or someone that they go to school with. So that is always something common that we do here at the behavioral health unit as well. It's a lot more common than you think.
So again, if we're thinking about homicidal ideations and that safety, if they're having lots of ideations, gestures, and any of these kind of groupings, if they have a specific plan and intent, and they're at that high risk level, then that could be means for a duty to warn. If you're thinking inpatient because of homicidal ideations, you should also be considering that duty to warn report then. Which leads us into step 4, so determining that level of risk. So we're taking all of that information, risk and protective factors, suicidality, and determining what kind of interventions we think is appropriate. The Safety Pocket Guide has this grid that we have shared here that you can refer to when in doubt. But it's also important to note that this is not a exact algorithm, or it's not supposed to be that just because this plus this means automatically they get referred to inpatient, or this behavior and this suicidality risk means they need to go to outpatient. This is still using your clinical judgment while also kind of thinking through these are particular situations that can lean towards one or the other ways for discharge. So making sure that you are always consulting and considering what are their risk and protective factors? How can we increase protective factors or decrease those risk factors? What is their suicidality? Is it imminent, right? And then does that mean we need to go inpatient, outpatient, outpatient with crisis, or otherwise? Step 5 is documenting. So all across, Multicare, we have smart phrases, right? So Mary Bridge has a specific pediatric mental health evaluation smart phrase that allows us to document very clearly what is going on with the patient and what our recommendations are. If for some reason you're not using that, it is important and a part of the safety assessment that you document your clinical judgment. So what is the risk level and why? What are your recommendations for interventions, inpatient, outpatient, et cetera? And what are you doing for that follow-up care? Did you make a referral? Is the patient agreeable to inpatient, et cetera? Just throwing this in here as well as some of the commonly used diagnoses when it comes to pediatric patients in crisis settings. The bolded ones are the ones we more commonly see. So that top row, depressive disorder, anxiety disorder, unspecified trauma and stress-related disorder. Again, using that CATS screener to kind of help identify if that is the more appropriate diagnoses. And then unspecified disruptive impulse control and conduct disorder. The rest of them might be ones that you see, but it's just less frequent for pediatric patients. Okay, so moving forward, now let's talk about disposition. So we're kind of in that step 5, step 4, where we're thinking about what's the risk and now how do we discharge them. We know with pediatric patients that it can be really difficult with the systems that be around discharging and getting patients set up with the most appropriate level of care and services. And so we're going to be talking about safety planning and then inpatient psychiatric care in the next few slides. So starting with safety planning, I put this here. So this is the suicide risk curve. I love this graphic because it really shows that suicidal ideations is on a spectrum and that the risk can change over time, increase and decrease based on stress, based on coping, based on supports, right? And so it's important that we think of the highest level of danger for suicidal ideations and acting on them is time. And something that we have learned, and it's going to be in a slides coming up here, is that safety planning is the best and most beneficial way to reduce the act based on suicidal thoughts. So creating a safety plan, creating the strategies for patients to use to increase time between thoughts and actions is the goal. And so we're going to be talking a little bit more about how we can do that and what are some best practices for pediatric patients. So in context with safety planning, we want to identify the suicide risk through that screening and comprehensive assessment. We want to complete safety plans, and that includes lethal means counseling for individuals with suicidal risk, communicate with families and caregivers about the plan and how they are going to be involved, and then regularly review those plans and revise them as needed. So if we have a patient that comes to Mary Bridge from another hospital, or we've been told by families that, hey, we have a safety plan, I would want to look at that, right? And I would also be asking the patient and family of what happened, why didn't we use it, why wasn't it effective, so that we can create a better one. So some common characteristics of an acute suicidal crisis. The biggest thing for this is again, that timing. Research shows that within 10 minutes of someone having a suicidal thought or ideation, they will act on it. So because we want to ensure that we are creating plans, safety plans that are going to mitigate or create more time, we want to make sure that that's the biggest way to reduce risk, right? So it can be difficult to predict, it can be unplanned, right? That's why that short period of time, up to 10 minutes, A lot of times people are acting impulsively, and we know with this population that their impulse control is already limited, and so they're more likely to act on that thought if they have access to it. So safety planning is important. Some statistics here around safety planning. What has been found is that 95% of people who attempt suicide are seen by a healthcare provider within the year prior to their attempt. Safety planning has been shown to lead to 45% reduction in suicidal behaviors compared to other treatments. And it can more than double the odds of a patient attending at least one outpatient session. So when we're safety planning with patients and we're identifying specific strategies for them to include follow-up, that increases their safety and their odds of supportive services once they've discharged from our hospital. So multi-care as a system, we use the Stanley Brown safety plan. There are templates of this through smart phrases across the system that you can use. Essentially, though, it's going over those warning signs. This needs to be person and patient centered. So having them identify what their warning signs are, what are their coping strategies, who are the people that they can go to for support. And the step 3 of the safety plan, it is okay for it to be peers. So when we're thinking about that step 3, we're thinking about who are the people you can contact for distraction. So not necessarily go to for help, but contact for distraction. So peers and friends, people in their social group, that's an appropriate person to list there. Step 4, people who you can ask for help, those need to be adults when we're thinking about this pediatric population. So coaches, teachers, relatives, those are adults that we want to make sure, because this is where we're saying, okay, if you haven't been distracted enough by talking to your friend, who are you going to reach out to ask for help, saying, I'm having these types of thoughts, I need to go get help. That's the persons you want to put in step 4. Step 5 is your professionals. So crisis line information, any particular specific referrals that you might be making for a patient for outpatient services, you could put that information there. And then step 6, which I think is the most important piece of it, is the making the environment safe or creating safety strategies at time of discharge. So this is the thing when we're thinking about increasing time between the thoughts and the action. Removing access to means. If someone says that they are having a plan to overdose, we remove access to medications in the home. That's going to reduce time, or increase time if they don't have access right then and there. So putting very specifically and very clearly what actions the patient or the caregivers are going to take at time of discharge to make the environment safe and increase time between thought and action. Okay. So now looking at who should receive a safety plan, right? So you're doing your assessment.
Jasmine, one thing really quick. Is there a way for us to email everyone that's here the instructions on how to complete a safety sweep of the home?
Yes.
Perfect.
Great call out. Absolutely. Thank you for asking that. So when we're thinking about safety plans and who should get one, right, we're obviously considering that risk assessment that we've done. But this is just kind of a more simple way to put it. Anyone who's at risk of suicide, anyone who's in a suicidal crisis, if they're having suicidal thoughts or are in distress and have had suicide in the past, attempted suicide in the past, those are all good candidates for a for a safety plan. So people who don't need to have a safety plan necessarily, someone who's not able to participate, right? So they're unwilling to engage in the process. That might mean other things and consider other disposition options. And those that are not at risk. So if you have a patient that comes in for a behavioral health problem, they're not endorsing any sort of suicidal thoughts, they've never had suicide attempts or gestures behaviors in their past, they don't need a safety plan, right? They might need a crisis plan developed to help manage behaviors, but not necessarily a suicide safety plan to manage risk of that. If mobile crisis teams meet with the patients and families outside of the hospital, so sometimes that is an option around the CCS, Catholic Community Services, or Seneca will sometimes meet the patients at their home after discharge. the social worker in the hospital still needs to document a safety plan. So a lot of times with Catholic Community Services, they will do the safety plan in the hospital prior to discharge. But with volumes, especially as we go into our more busy season here, if there's the capacity for them to meet at the home and you're able to do that, please make sure that you as the social worker are still documenting a safety plan for them to go home with. And then that can be updated with their crisis team once they've met with them. And then finally around safety plans is just some developmental considerations. As we know, we've had an increase in patients with neurodivergence, maybe some nonverbal. And so wanting to make sure that we are using things that are developmentally appropriate, even if we're doing a safety plan or have concerns about risk. So use modified language or images, creating something like what's shown here. You might have to put pictures instead because that's the way that patient understands. You want to make sure that you're collaborating with the patient and families around what makes sense for them. So keeping it patient-centered, allow for autonomy and guide to make sure that what is being suggested or requested makes sense to maintain safety. And consider all of the environments that the patient spends their time. So if they're in separated households, so one parent living or two parents living apart, excuse me, we want to consider and think about how does the safety plan work in this parent's home and in this parent's home, and that it is tailored to that. If we know that suicidal thoughts or ideations are more frequent in school settings, we want to make sure that the safety plan addresses that and that we're putting those considerations in it. So just really thinking through how and why, how we are providing that safety plan to them in a way that is appropriate for them to understand. Okay. Finally, thinking about caregiver engagement. So this is a different process, right, with pediatrics. We're not just talking to the patients, but we also have to engage and talk to their caregivers. So as soon as we know that the patient is needing a mental health evaluation, we need to make sure we're including those caregivers. Again, about the consent and confidentiality pieces, sometimes we get patients brought in by EMS and parents aren't available. So if they're 12 and under, you do need to get consent to talk to that patient without their parent present, so calling ahead of time. If they're 13 and over and a parent's not present, talk to the patient and call the parents to make sure you're getting their version of the events, gathering history about the patient. And so it's really important that we gather as much information as possible from caregivers about what's going on, because that's how we can ultimately discharge safety plan or getting consent for inpatient treatment. You also want to make sure that you have some cultural sensitivity and understanding, right? Every family is different. Every family operates differently, whether it's spiritual, cultural, or ethnic beliefs that they have. It's important that we incorporate that and we consider that when we are working with them. Making sure you talk about minor confidentiality and risks of suicide to the patient, and that you're explaining very clearly, hey, the patient disclosed to me that they were thinking about overdosing. We want to make sure that they're safe if they discharge home. Can we make sure to lock up meds, right? That we do lethal means counseling, so firearms, that we're having those conversations. We're asking directly about firearms in the home, how they are stored, and if there's anything we can do to support and securely storing their firearms to help reduce risk. Make sure you review the safety plan with patients and their families. If their caregivers are refusing to engage in behavioral health services, considering referrals to CPS for negligence, as well as that consideration for a DCR referral if the patient is not voluntary on their own. Make sure you're documenting all of your contacts. And then again, making sure you consider all of the environments that that patient is in. So again, if you have a separated household, one parent brings the patient in, ask about visitation with the other parent, ask about firearms in that other parent's home, call the other parent to make sure that they're all on the same page because we want to ensure safety is at the utmost priority, regardless of any social situations that might be going on between households. All right, I'm going to go ahead and transition over to Heather here. Heather, just let me know when you're ready for me to move forward with slides.
Thank you. Okay, so everybody's done all their work. You've done the assessment, and then you are thinking about sending the patient either to an inpatient, to an intensive outpatient, or to a partial hospitalization program. which you have access to all three, and we'll have a resource list available later on this. Typically, what we have said in the past and what we have used on either in the ED or on the medical surgical floors here is that if the patient has their suicide attempt was significant enough that they are going to be admitted for treatment, they would most likely benefit from the high risk level of care, which would be psychiatric treatment in a secure setting. If they're coming in with SI or suicidal ideation and they have a plan but with no intent or behavior, they may or may not need an inpatient stay, but you will do some significant crisis planning with them. And then you will also discharge with potentially with crisis services or risk services, such as CCS, WISE, or Seneca. What I've always told parents in the past, and when we have these situations with kids who are at this moderate level, who have the multiple risk factors, they've had some behavioral health symptoms in the past, is that you really want to you really want to consider how available you are and how adept you are at being able to keep the child safe at home. If the parent isn't able to complete the steps in the safety plan, then at that point, then you would probably talk to them about referring to an inpatient setting or an IOP or a PHP. If they're a low risk, then you're going to do with thoughts of death, but with no plan, no intent or behavior, then you can refer them out to services with either an IOP or a PHP program, and we're going to talk about those in just a minute. And then you're still going to safety plan and give a warm handoff to something like CCS or Seneca to help set up the family at home to provide more services. Next slide. So I do want to talk to you about what our inpatient pediatric unit looks like here. We're actually located on the first floor of the Rainier Tower at Tacoma General Hospital. We are a 27-bed facility. However, our max capacity here is 26 beds. We are also what we call an acute care facility. We're not a long-term facility. We are not a residential treatment facility. Our goal and purpose here is to get your child stabilized so that they can discharge back home with further services in place. Our average stay here is just about 6.5 to 7 days. Our social work team here is responsible for completing the psychosocial assessments and doing the discharge planning with our patients. Every patient here we do a safety plan with before they discharge home. And we go over that safety plan not only with the patient, but we talk to the parent too, and then we talk about what the home and the environment looks like when the child is discharged home for safety for both. And one of the things that we were talking about, like when Jasmine was talking about just depending on what the social situation is with the family, what you have to think about is if a lot of these kids have this, if they are splitting custodial relationships for parents, each parent's house has to be safety swept. It's not just one or the other. Both need to be safety swept to the same level to keep the child safe. We can also make referrals to residential treatment facilities from here. However, the patient will not stay here while waiting a bed to become available. And that's one of the biggest things that we run into with families here is that the parents will drop their child off and then they don't want to pick them up until a residential treatment bed is available. While we will do our best to secure a residential treatment bed for a child, we cannot hold them here for 2 to 3 weeks until the bed becomes available. In that case, what we will normally do is do some heavy safety planning with the family. We'll come up and have a complete plan about who's going to watch the child, what the school plan is going to be, what the house safety suite needs to look like, and do a complete safety plan with the parent and the child together and make sure that everybody is comfortable in discharging home. We are also an all dialectical behavioral therapy treatment team here. So everybody here all gets DBT, which is the best evidence-based practice for what the majority of our kids come through, which is major depressive disorder. Every day, all of our kids, no matter how many patients we have, each patient will meet with their individual provider to discuss how they're feeling and if any medication changes need to be made or if medications need to be introduced. They do have 5 individual groups that they go through each day not individual groups. They go through 5 groups per day, 3 with a therapist, 1 with a mental health technician, and 1 with the social workers. And then they have other planned activities for the day for them. Our kids stay up from 8 a.m. to 10 p.m. in the evening, so we have a ton of activities for them throughout the day. Jasmine, next slide. So when we're talking about this is the same thing for referring to an inpatient psychiatric unit. Our unit takes from 13 to 17-year-olds. They can either come in voluntarily, where the patient is willingly agreeing to come in for treatment. When they come in, one of the things that we tell them is that they know that they can request to be discharged early if they're here voluntarily and they feel that they're not benefiting from the program. They can actually write a letter here to be discharged early. If the provider feels that the patient would benefit from the full length of stay, which would be the full 7 days, they will ask the parent or caregiver to consent and switch the child over from a voluntary admission to a fit admission or a family-initiated treatment. If the family or the parent caregiver declines to fit the child, then the patient will be discharged from our unit 48 hours after the letter is received. Under a family-initiated treatment, the patient comes here after declining treatment, but the parents are inserting their right to sign the minor in for treatment. The child will stay here for the full 7 days unless the family decides to revoke their family-initiated treatment and says that they want to remove the child sooner. In that case, too, the provider will talk to the parents to see if they will allow the child to stay for the full 7 days for treatment if needed. If not, they may let the child discharge with the parent, but it would be against medical advice. The last way a child gets here is through the ITA, which is Involuntary Treatment Act. That's when they're detained by the DCR after the parent, caregiver, and minor do not agree towards treatment. The patient meets criteria under the ITA law for detainment, which means that they're a danger to themselves or others, or they're gravely disabled. The patient's legal status, once admitted, will be continually assessed, and detention timelines vary based on patient presentation and symptoms. Under this policy, under the ITA treatment, the first detainment is for 120 hours. That does not count weekends under the first 120 hours only. Past that, should we put in for a 14-day detainment, it is straight 14 days, counting weekends, counting everything. And once that 14 days is done, we would either release the patient or we would release the patient, dropping the detainment, or we would put in for a further 90 to 180 days. We can also release a child from detainment under 120 hours if the parent decides to go back to voluntary treatment and do family-initiated treatment instead. And I'll answer questions about that at the end. Next slide, Jasmine. So this, talking about the ITAs, the patient can be admitted under the initial 120-hour detainment. The weekend hours are not included in the 120. The patient will be seen by the provider, and the provider determines if the patient meets the criteria for the 14-day detainment. This is a very tough idea for parents to accept, but it is always down to what the provider determines if we're going to extend the detainment. They certainly do take what the parent says into consideration, but ultimately it's the provider's decision if we're going to extend the detainment. The provider will also speak to the parent about changing to family-initiated treatment so the patient can stay for the 7 days of treatment versus going home after the 120-hour detainment. That is if they are here on a detainment and the provider believes that they could benefit from a longer stay, they will ask the parent to change to family-initiated treatment, in which case we would drop the detainment and keep the child just for the 7 days. And if the parent does not sign a family-initiated treatment before the ITA ends, which is the 120 hours, the patient must be discharged at the end of the 120-hour ITA if not detained further. So we would have to safety plan, make arrangements for a primary care provider, a therapist, and any other residential treatment referrals as needed, and then we would discharge the child. Okay, next one, Jasmine. When a patient is detained and a bed is not available at a psychiatric unit, the patient may be placed on a single bed certification at a multi-care hospital. That would be on the inpatient unit if they're allowed. When this happens, the DCR is filing a petition that indicates that the hospital provider can provide the required single bed certification treatment conditions for the patients. At Mary Bridge, when we do have a single bed cert, we do only have one bed upstairs on the medical surgical floor that is available for single bed certification for the patient, which is more like a regular hospital room. The patient will be admitted to the hospital. You will work together to develop and document an individualized behavioral health treatment plan in consultation with the patient. With this plan, though, you're also going to have to involve the legal guardians, and that also may include medication management. That's up to the provider. You'll have daily contact with the behavioral health provider and the social work daily reassessment to make sure that the child is still meeting the criteria. And the single bed cert at multi-care hospitals ends with the patient transfers to an accepting psychiatric unit. A new single bed cert is created for the next facility by the DCR. They're responsible for that. And the treating physician or hospital admin determines that the patient no longer requires inpatient treatment, which results in the detention being dropped. And I know that's a lot of information. We can also send out these slides, and we're also available for consultation for that. Anytime that there's a question, I know I'm available for that. If you have any questions about this, I think there's a lot of questions always about single bed certs when it comes to multi-care, just because we do run into the situation, especially at this time of year where we're ramping up again, and a lot of the psychiatric facilities are full on beds, that you do end up having these kids waiting in the inpatient units for beds in psychiatric facilities, and single bed certs are required. So, and there is a, Jasmine, do you know if everybody here has access to the SBC note? Because there is a
Yeah,
specific one.
yeah, everyone should. So Mary Bridge has a ITA note for our pediatric patients. It's really similar to the mental health evaluation note, but it has those ITA goals at the bottom. So similar to, I think for the adult patients, your guys' smart phrase that has that ITA goals section, we have that in our note as well.
And it's pretty intuitive for the note, and it tells you exactly what we need to know in order for the single bed cert to be active. Next slide, please. And then you want to go to the flow sheet section under the mental health disposition daily to do the mental health evaluation. And this is what it looks like. It looks like on the flow sheet when they're medically cleared for the mental health evaluation, and what time and date, what type of assessment that they're getting done, when it was completed, and the time. All of this information goes on to the single bed certification. Next slide. And then so our workflow for patients on ITA, it's kind of it's a busy one. So the first thing that you're going to do is confirm that the patient has inpatient admissions order. So any room change decisions are made by hospital administrators and unit leaders. Social work can provide informed clinical judgment based on patient presentation / behaviors. Typically what this looks like in the inpatient unit is that we will usually have a quick staff huddle with the provider, charge nurse, social work available so that we can discuss what the room needs to look like for any mental health evaluate or any mental health patient that needs to be boarding while they wait for an inpatient bed. If you don't have a mental health room like we have at Mary Bridge, then you want to make sure that the things are removed to keep their room as safe as you would have it in like an ER. So for that here, what that normally looks like is that they remove a lot of the lines and equipment that are tied to the walls in the rooms on the med-surg and the PICU floors. Any strangulation items are removed, so any cords or cables. That includes the TV remote until they're cleared by social work to have TV, and then at that point, then the room sitter becomes the TV monitor and monitors that cord for the remote. They remove all hanging items, including shower curtains and the curtains at the room doors, just to make sure that the patients are safe too. And then we usually would get together with the last huddle before the patient is admitted to make sure that the room is completely safety swept and that the patient is ready to go, so that we limit the risk that the patient would have at the hospital. You're going to scan your completed ITA packet and send it by email to your utilization manager. And then you're going to develop and document an individualized behavioral health treatment plan, which we just talked about. This is our ITA daily reassessment note. The patient's legal guardians need to be consulted on creating this plan, because it may also include medication management. And you always want to have parents knowing what the child is taking, so that if they're discharged with medications, they know what to look for and when the medication needs to be dosed. You'll have daily contact with the BHP and the social work daily reassessment. And you will consult with psychiatry. We have ours on staff here at Mary Bridge too, which is within 72 hours of detainment, or as soon as possible if patient is exhibiting symptoms of psychosis or mania, in case we need to develop two things. One is a medication plan, and one is the second thing is we would always get together with a huddle for medication management for agitation. And then you will start your behavioral health unit screening expectations, which is the day one, the DCR does this. They search for a bed, and day two, hospital social work takes over. Jasmine, next screen. I know that we're coming up to the end. With treatment planning, you want to talk about with the presenting symptoms, not compliant with medications. One that's very common is not engaging in their activities of daily living. Command hallucinations, telling patients to harm others. They have access or active SI and a plan. And you want to increase, their goals would be increase medication compliance, increase compliance with personal care, decrease aggressive behaviors towards others, and develop at least 2 new coping skills to maintain safety when experiencing SI. Next one. If their presentation changes while they are admitted, you want to update the safety assessment. So you shouldn't just be cutting and pasting daily. You want to look at what is the patient saying, how are they actually behaving, and document your interactions with the patient. Not only your current interactions, but how it has changed over time, and how they're acting with others, like visitors, staff, family, if they've had any code grays called. Are they currently engaged in completing their ADLs on their own, eating, drinking, showering, walking, etc.? And are they endorsing ideations for suicide or homicide? And even if they are not, but they are behaving in a way that contradicts what they, are they behaving in a way that contradicts what they're saying? And are they demonstrating insight into their own suicidal, homicidal thoughts, or are they becoming better or worse? The thought program, not the individual. Next. And then, so we're looking at, this is just a standard timeline here. We're talking about the initial 120-hour detention must be evaluated by the DCR. If they're still not safe for discharge and a less restrictive alternative at the end of detention period, or a less restrictive alternative at the end of the detention period, then we would pursue a 14-day commitment or 14-day detention. That, again, is not counting the weekends. If they're still not safe for that, after that, then we would consider a 180-day detention, at which point they would probably transfer out of our acute care facility, and they would look at a longer-term placement like a CLIP facility. Next.
One thing I just want to add, so the biggest difference here for our adult hospital partners is that we don't have a 90-day for pediatric patients. So I know that between 14 and 180, the adults do have the ability to be detained for up to 90 days. So that doesn't exist here. And then also, if you note, who is writing the petition. So I believe all of the hospitals have someone who writes petitions within your facility. So for pediatric patients, The 14-day can be written by the social worker or the physician, but the 180-day petition has to be written by a child psychologist. So thankfully, we at Marybridge do have a psychiatrist that's available and able to write those, but that might be a limitation for other hospitals. So I just wanted to point that out as well.
And what if the risk has decreased, as it often does once medications are started and the child starts to improve? Upon reassessing the patient on an ITA, if it's felt that the risk of harm to self or others or grave disability is no longer a concern, the social worker will consult with two people, both the provider and the supervisor, together, and come normally into a huddle to discuss their concerns about least restrictive options that could be pursued at that time, which would mean that it would end the detainment and that the patient could engage in crisis services or other outside psychiatric services that would keep them safe. Some examples of this is the patient is within behavioral control and is no longer endorsing suicidal or homicidal ideations and can clearly state why these symptoms have improved, and the patient is compliant with medications and signs of grave disability have decreased. And that's typically what we see. I would say it's pretty rare for kids to be placed on the 180 unless they're one of our, honestly, it's one of our frequent flyer patients that are returning for the 6th or 7th time this month. And they are really declining in their abilities to care for themselves and are not able to keep themselves safe at all. I would say the majority of our kids are usually released after the 14-day detainment. And then a notice of release or an NOR must be completed and submitted to the DCR. Next. And so my last thing that I wanted to provide to you all these are the resources that are available for minors. Charlie Health does a virtual IOP for teens that incorporates groups, individual therapy, and family therapy. They are also able to take Medicaid now. They're a great virtual IOP program for the kids. Fairfax Behavioral also has an intensive outpatient and a partial hospitalization program. Sorry, one last thing, going back to Charlie Health, that's a 6-week program. Fairfax is also a IOP and PHP programs, both in Bellevue and Kirkland. The Teen Day program, they're asking for a 4 to 6 week commitment, and the IOP program, which is 3 to 5 days a week, they're asking for a 6 to 8 week commitment. With their PHP, they will do 5 days per week, and then they will go home every night, and it's usually for 4 to 5 hours at a time. Navos is our own PHP program, which is a Monday through Friday DBT program that continues on with the DBT programming that is provided here at the ABHU. Children are, the program starts itself on every Monday, and the kids are there Monday through Friday from 2 p.m. to 7 p.m. and then return home in the evening. This is an in-person program, so the child needs to commit to actually being in person in Burien for this program. And if you have patients that are interested in that, they can call Nicole directly.
One little caveat is that Charlie Health and Navos, and probably for Fairfax too, you can refer before they discharge. So you can submit those referrals. The Charlie Health one is online, and then they'll reach out to the families directly to get them started. They have a 72-hour turnaround for intakes usually. And then Navos, like Heather said, they're every Monday they can be started into the program. And if it's an internal referral, so from one of our multi-care facilities, they work pretty quick to get those patients in.
Yeah, I would say for Navos, you'll probably get a response with an acceptance or not within 24 hours.
Yeah. And it's just an MR. Sometimes I think you can just do an MRN referral too, and they'll look at the chart.
Correct.
Last slide here. So just some brief considerations for pediatric patients. We recognize that it might not happen often, but it does happen where you have a patient that shows up. And so we want you guys to know that you can consult with social workers at Marybridge. So we cross-checked with our legal partners as long as you are providing information minimal necessary. So no MRNs, no specific HIPAA violating information. If you give us a brief SBAR on patient's age, what's going on with them, and what your question is, we can support and assist with you on those patients to help navigate. Also considering Kids Mental Health Washington or Kids Mental Health Pierce County for multidisciplinary team meetings. Those are great services within our communities that can help navigate our more complex behavioral health patients that need a little bit more support prior to discharge, and that might end up boarding in your ERs waiting to get connected to services. So utilizing those resources is also important. And then the last thing around hospital holds, I know that this has been a really hot topic in Marybridge, and so I also just kind of wanted to put a plug in regarding this. So hospital holds for behavioral health patients under the single bed certification policy, we can place a hospital hold, but it does require that we call the DCR. So I like to think about this the same way we would do a hospital hold for a pediatric patient with child welfare concerns, and you call CPS. We are placing a hospital hold for behavioral health concerns. They're in imminent danger, and we need to contact DCR to further evaluate. As you guys know, the same rules apply when we're doing DCR referrals. So patient needs to be medically stable. You have to have assessed them already. So what is your clinical judgment and recommendation? If they don't meet criteria, then you should not be placing a hospital hold, because what are we holding them for? We want the DCR to come and assess, but if they don't meet criteria, then a DCR referral is not appropriate. And so just wanting to make sure that there's some understanding around that. Happy to answer questions. It has been updated in our single bed cert hospital hold policy, some workflows to help support our social workers when those questions come up. All right, that is all we have for you today. I know we're a few minutes over, but I'm able to stay on, Heather, if you have to leave, no problem. Happy to answer any like last minute questions if anybody has them. Feel free to unmute yourself or drop them in the chat. Otherwise, our contact information is here. You're welcome to email us directly, Teams chat us, or reach out to Layla and Laura and Noelle. If you have any questions, we can connect with them. I'll make sure to send out copies of the slides, the recording, as well as I saw the CATS form. I'll send you guys copies of the CATS form as well. But does anyone else have any questions that you'd like answered before you go today? Feel free to unmute yourself. That's probably the easiest. Okay. All right. Well, I will stop the recording. Thank you all so much for your time. Again, reach out if you have any questions or concerns. Thank you.